acute acute lymphoblastic leukemia. In acute lymphoblastic leukemia, the malignant clone in acute lymphoblastic leukemia, so this malignant clone, this arises from hematopoietic progenitas in the bone marrow or the lymphatic system. So where is this malignant clone arising? So this malignant clone is arising from the hematopoietic progenitas in the bone marrow or the lymphatic system. So this will result in an increase of the immature non-functioning leukemic cells. So where is this malignant clone arising? So this malignant clone is arising from the hematopoietic progenitas in the bone marrow or the lymphatic system. So this will result in an increase of the immature non-functioning leukemic cells. So this immature non-functioning leukemic cells, they infiltrate the bone marrow. So if this immature non-functioning leukemic cells, if they infiltrate the bone marrow, so this will lead to anemia, this will lead to granulocytopenia, and this will lead to thrombocytopenia. So because of this anemia, what will happen? There will be fatigue and weakness. Because of granulocytopenia, there will be infection, and because of thrombocytopenia, there is hemorrhage. So in acute lymphoblastic leukemia, malignant clone is there. So this malignant clone, it is arising from the hematopoietic progenitas in the bone marrow or the lymphatic system. So this malignant clone, because of this malignant clone, there is an increase of the immature non-functioning leukemic cells, and this leukemic cells are going and infiltrating the bone marrow, and because of this, what is happening? There is anemia, granulocytopenia, and thrombocytopenia, and there are clinical manifestations of fatigue, weakness, infection, and hemorrhage. So these are the symptoms. So what are the symptoms? Fatigue, weakness, infection, and hemorrhage. These symptoms are more often the reason why a patient first seeks medical advice, rather than patient coming and telling that patient has got some lymph node enlargement, or patient telling that hepatosplenomegaly which is caused by leukemic infiltration, or instead patient having central nervous system symptoms which is called as meningiosis leukemica. Okay, so instead of this, what are the most common clinical manifestations, how the patient presents to a clinician? So these are the fatigue, weakness, infection, and hemorrhage. What is the incidence? So ALL, so this is the most frequent neoplastic disease in children, with an early peak at the age of 3 to 4 years. So what is the most frequent neoplastic disease in children? So ALL, acute lymphoblastic leukemia. So what happens in these children? It occurs at the age of 3 to 4 years. Even incidence in adults, so the incidence in adults also ranges from 0.7 to 1.8 per 1 lakh per year. So even in adults, the incidence is 0.7 to 1.8 per 1 lakh per year. And this incidence, it is somewhat higher in adolescents and young adults. In adults, no, in which age group it is common? So this is more common in adolescents, and this is more common in young adults. Decreasing in adults, but again, no, so this acute lymphoblastic leukemia, it is increasing again in the elderly people. So if we take this Philadelphia chromosome positive ALL, okay, Philadelphia positive ALL, Philadelphia positive ALL with a BCR ABL translocation. So this is observed in half of elderly B lineage patients. So in what percentage of elderly patients this Philadelphia chromosome positive ALL translocation is observed? So this is observed in half of elderly B lineage patients. And the frequency of the immunologic, cytogenetic, and genetic subtypes changes substantially with age. Okay, with age, what will happen? The frequency of immunologic, cytogenetic and genetic subtypes of acute lymphoblastic leukemia. It changes substantially with age. Etiology. What is the etiology? The etiology of this acute leukemias, it is unknown, but internal and external factors influence the incidence. So what are these internal and external factors? If we take this AML, so this AML, like acute myeloid leukemia. So this acute myeloid leukemia, if there is an exposure to ionizing radiation or to chemicals or to prior chemotherapy, there is an increased risk of developing leukemia, but it is more often observed in acute myeloid leukemia. If we take this ionizing radiation or chemicals or prior chemotherapy, all these are the risk factors for development of leukemia, but mostly this is observed in acute myeloid leukemia. But this increasingly secondary ALLs, this secondary acute lymphoblastic leukemia, so this has been observed particularly after cytostatic treatment with alkylating agents and topoisomerase inhibitors. So if a patient would have undergone treatment with alkylating agents or with topoisomerase inhibitor, so where are these agents used? So these agents are used primarily for acute myeloid leukemia, for myelodysplastic syndrome or breast cancer. If patient would have undergone treatment of these AML, myelodysplastic syndrome or breast cancer with these agents, with alkylating agents or topoisomerase inhibitor, they have got an increased incidence of secondary ALLs. And this congenital disorders. So this congenital disorders are very important from MCQ point of view as well as in theoretical point of view. So this rare congenital chromosome abnormalities, they have a higher risk of acute leukemia. So you have to remember these congenital abnormalities. So what are these? These are Fanconi's anemia, ataxia telangiectasia, Bloom's syndrome. So what are the congenital chromosome abnormalities which are associated with a higher risk of acute leukemia? So these are nothing but Fanconi's anemia, ataxia telangiectasia, Bloom's syndrome, and also Klinefelter syndrome as well as neurofibromatosis. Klinefelter's and neurofibromatosis. So all these rare congenital chromosome abnormalities, they have a higher risk of development of acute leukemia. Patients who are having Down's syndrome, they have a 20-fold increased incidence of leukemia. Down syndrome patient, they have a 20-fold increased risk of leukemia. ALL is increased in childhood and AML, it is increased at an old age. So in Down syndrome patients, how many fold there is an increased incidence of leukemia? So there is a 20-fold increased incidence of leukemia. ALL, it is common in childhood and AML is common in the older age. Infectious agents. No direct evidence implicates viruses as a major cause of human acute leukemia. No direct evidence. There is no direct evidence that this virus is a cause of acute leukemia. But viruses are involved in the pathogenesis of two lymphoid neoplasias. If we take this endemic African type of Burkitt's lymphoma, Africa, okay, Burkitt's lymphoma, the Epstein-Barr virus, a DNA virus of the herpes family. So this has been implicated as a potential causative agent. Africa, endemic Africa, Burkitt's lymphoma, which is a virus, Epstein-Barr virus. So this is a DNA virus. And if we take HTLV1, okay, HTLV1 virus, it causes, this is human T cell leukemia virus 1. Where is this observed? Japan and Caribbean. This has been a etiological agent for rare causes of adult T cell, adult T cell leukemia lymphoma. Two viruses, Epstein-Barr virus and HTLV1 virus. Epstein-Barr virus, endemic Africa, Burkitt's lymphoma, it is a DNA virus. HTLV1, Japan and Caribbean islands. Adult T cell, okay, it's not B cell, okay, it is T cell leukemia lymphoma. Diagnosis and classification. How to make a diagnosis of acute leukemia. The diagnosis of acute leukemia, this is first made by examination of the peripheral blood and bone marrow. So if we suspect any leukemia for any patient, what we have to order? First we have to order for examination of the peripheral blood and bone marrow. And for further classification, so we have done a peripheral blood, a bone marrow is ordered, and then again further we have to classify the leukemic blast cells. For these, further tests are required. So these are cytochemical stains, immunological markers, and cytogenetic and molecular analysis are required. Initially, supposing a patient has come to us or come to a clinician with presentation of lymph nodes, lymphadenopathy is there, we are suspecting some leukemia or lymphoma. So first what has to be done? First, a peripheral smear has to be ordered, and then a bone marrow examination has to be done. And later, and we need further classification of these leukemias. So for these, what should be done? We have to order further tests. So what are these further tests? So these are immunological markers, cytogenetic and molecular analysis, and cytochemical stains. The immunological markers, they are still the major criteria to subdivide into B cell lineage or T cell lineage. So first we know that it is a lymphocytic leukemia. So we have to know which leukemia it is, whether it is a B cell or whether it is a T cell lymphoblastic leukemia. For that, what is required is immunological markers are required. So immunological markers, they are still the major criteria to subdivide into B cell lineage or T cell lineage ALL leukemias. ALL means acute lymphoblastic leukemia. So we have to know whether it is B cell or T cell. So to tell whether it is B cell or T cell, we need immunological markers. So peripheral blood counts and a differential count from a right James stained blood smear are essential at the time of presentation. If we take the white blood cell count in 40% of the ALL patient, it is reduced or it is normal. Only 16% of the patients have a WBC count above 100 into 10 per 5 per liter, or 1 lakh or 10,000. 10,000 is normal, so something above 10,000, okay. So the WBC count, maybe it could be 50,000, 60,000, but in 40% of the patients, WBC count, so peripheral smear is ordered, is suspecting in view of acute lymphoblastic leukemia. So if we look at the WBC count, 40% of the patients, they have this WBC count reduced or it will be normal, but 16% of the patients, no, when we have this, when we check for this WBC count, it could be 60,000 or 70,000. And no, it is noteworthy that 8% of ALL patient, no circulating leukemic blast cells were observed. In peripheral smear, what can we see on the peripheral smear? We can see the blast on peripheral smear. But in 8% of the patients, no circulating leukemic blast cells were observed. So we use this automatic blood cell counting, no, the diagnosis may not be detected. That is why a peripheral blood smear. So we have to order for a peripheral blood smear. So in this we can show anemia, we can see anemia, thrombocytopenia and neutropenia. And apart from this, we can also see the blast on a peripheral smear. Nearly one third of the patients, they have hemoglobin levels because the cells are going and infiltrating the bone marrow. So because of this, what happens to the hemoglobin levels? They'll be in the lower range. Platelet counts also will be low, that is 20,000, or neutropenia. Neutrophils will be less than 500. So because of this low neutrophil count, neutrophils are generally required for counteracting the infection, but if there are low neutrophils, there is a higher risk of infection. And this is the peripheral bed smear of a acute lymphoblastic leukemia. Here you can see the so all these are the blast with these are small, these are uniform blast with how is the cytoplasm? So there is a scant cytoplasm and inconspicuous nucleoli. So all these are the blast. Small uniform blast with scant cytoplasm and inconspicuous nucleoli. So these are the laboratory investigations. So these data are taken from 3 consecutive multi-center trial. Supposing we have ordered for a total count or a complete blood picture. So what can we see on the complete blood picture in 1273 patients? Few patients, no, they have this white blood cell count greater than 1 lakh. Or few patients, they'll be having white blood cell count less than 10,000. Few will be having 10 to 50,000. Neutrophils will be low in few patients, and platelets, few patients they'll have platelets greater than 1 lakh. Few patients will have less than few percentage, no. So this is a different from different trials. So this statistics have been taken. Hemoglobin, few patients will be having hemoglobin greater than 9, few greater than 7, and 36% of the patients, they have this leukemic blast in the peripheral blood, that is greater than 75% blast will be there. And bone marrow, leukemic blast in the bone marrow, these are seen in 71% of the patients. So in bone marrow, like with accuracy, we can see in 90% of the patients. Bone marrow examination. So bone marrow, we can do a aspirate or we can do a biopsy of the bone marrow. So this aspirate and biopsy, bone marrow, we are doing a aspiration and we are doing a biopsy in the bone marrow. So this aspirate and biopsy, these are important to assess the immunological, cytogenetic and genomic markers. So from bone marrow, a direct smear is taken. So this will confirm the diagnosis of acute leukemia. Blast cells will be there on the smear, and this also confirms the whether it is a AML or whether it is a ALL. Bone marrow is done. So in bone marrow we can find blast, and from bone marrow we can say whether it is a myeloid leukemia or whether it is a lymphoid leukemia. And for further classification of this acute lymphoblastic leukemia into B cell and T cell, what is required? Immunological studies are required for further classification. So from bone marrow direct smear, we can differentiate whether it is a AML or whether it is a ALL. The bone marrow, it is usually heavily packed with leukemic blast cells. So in bone marrow, we can see blast cells in greater than 90% and in 70% of the patients. So because of this leukemic blast cells are increased in the bone marrow, what is happening to the normal hematopoietic cells? The normal hematopoietic cells are greatly reduced or absent. And if we do a biopsy of the bone marrow, it will further demonstrate. What can we see in the biopsy? There could be a marked hypercellularity with replacement of fat spaces, normal elements, and occasionally we can also see increased fibrosis. So because the cell count is increased, no, so there will be a marked hypercellularity. Even the fat spaces, they will be replaced by these increased malignant cells, and even normal elements, and occasionally we can also see fibrosis on the bone marrow. So this is the bone marrow aspirate of acute lymphoblastic leukemia. So these shows the lymphoblasts with variable sizes. So all these are lymphoblasts with variable sizes. There is a scant cytoplasm. There is vacuolation in a few cells, and there are also convoluted nucleus. Lumbar puncture. The examination of the CSF, it is an essential routine diagnostic measure for ALL. So if you are suspecting ALL, examination of the CSF, it is a routine. So when can we say that patient has got a central nervous system leukemia? So we can say that patient has got central nervous system leukemia if there are greater than or equal to 5 cells per microliter or leukemic blast cells observed by morphology in CSF. To detect whether patient has got CNS leukemia, what we have to do is we have to do a lumbar puncture, and in the fluid, what we get in this lumbar puncture fluid analysis, we have to observe for leukemic blast cells or greater than 5 cells per microliter. So this lymphoma cell, leukemia cell, so this in cerebrospinal fluid, this says that patient has got a CNS leukemia. And there are different opinions when first lumbar puncture should be done. So like different opinions means, first either we should delay the lumbar puncture or we should do a lumbar puncture early. Why this two differing opinions? So delay lumbar puncture until remission is achieved. Supposing patient doesn't have a CNS leukemia, so if you are doing a lumbar puncture, there is a chance of seeding of the CNS with leukemic blast cells from the peripheral blood during the spinal tap. So during the spinal tap, there could be seeding of the central nervous system with leukemic blast cells from the peripheral blood during the spinal tap. Or if we do a lumbar puncture before treatment starts, because we will be recognizing early CNS disease. If we do early lumbar puncture, we can recognize CNS disease early. If we delay the lumbar puncture, why lumbar puncture is delayed? To avoid seeding of the CNS. And lumbar puncture, so this is restricted to patients with an adequate platelet count and without manifest clinical hemorrhages. So if before doing a lumbar puncture, we have to see that platelet count it is greater than 20,000 and there is no significant clinical bleeding. And supposing if we have done a first lumbar puncture, to eliminate the potentially transferred blast cells, patient should receive intrathecal methotrexate. So at the first lumbar puncture, we are detecting for detecting CNS leukemia. If patient has undergone lumbar puncture early, then what we have to do? We have to give this intrathecal methotrexate at the first lumbar puncture to eliminate potentially transferred blast cells. Morphological subtypes in ALL. The FAB classification, so this is French, American, British classification. So this distinguish 3 subgroups. L1 and L2 morphology, this has got no clinical significance. Only the L3 morphology, this L3 morphology, so this is observed in 5% of adult patients. So if there is a L3 morphology, so this is indicative for mature B cell lineage ALL. So ALL, no, we have seen whether it is a B or T ALL. So we have to differentiate this using immunological studies. And in B also we have to know whether it is a mature or whether it is a immature B cells, mature B cells or immature B cells. And a series of monoclonal. Okay, so then we have this immunological classification. So what is the aim of the immunological classification? The aim is to subdivide ALLs again into B cell or T cell markers. So a marker is considered positive if greater than 20% of the cells are stained with the monoclonal antibody. So B cell will be there, okay? On B cell, few antigens are there. So what we are doing, we are giving a antibody and we are detecting the marker on this B cell, okay? We are detecting the marker on the B cell. So a marker is considered positive. So all leukemic cells are there if greater than 20% of the cells are stained with monoclonal antibody. Supposing T cell, if we stain this T cell with antibody, so this antibodies, it's specifically designed only for B cell antigens. So if this antibody, if T cells are there, this won't stain the T cell. So this is how immunological classification is done. A marker is considered positive if greater than 20% of the cells are stained with the monoclonal antibody. There are different immunological classifications such as that of the European group for the immunological characterization of leukemias with clear therapeutic implications and immunological subtype cytogenetics. And then coming to this B cell lineage ALL. So we have done a immunological study and we have found out that it is a B cell lineage ALL. More than 70%. So if we take ALL, okay, so we have B cell and T cell. More than 70% of adult ALLs or B cell origin. So this B cell lineage, how many percent? 70% or B cell origin. And the most frequent in this B cell, it is common ALL. The most frequent immunological subtype, common ALL. So this is characterized by presence of the ALL antigen CD10 without markers of relatively mature B cells such as cytoplasmic or surface membrane immunoglobulins. So if we take this, okay. So B lineage ALL is there. So in B lineage we have different types of this, which is the most common. It is common ALL. So in this common ALL, which marker is positive? CD10 is positive. Okay. So this common ALL, it will have antigen CD10, but there won't be markers of relatively mature B cells such as cytoplasmic or surface membrane immunoglobulins. And then we have this pre-B ALL or early B ALL. So this pre-B ALL or early B ALL, so this is characterized by the expression of cytoplasmic immunoglobulin, which is negative in common ALL but otherwise is identical with respect to all other cell markers. If we take this pre-B ALL, so this is characterized by expression of cytoplasmic immunoglobulin. So this is negative in common ALL. Again, if we go to this pre-B ALL, CD10 positive or negative, but here what will happen in pre-B ALL, cytoplasmic immunoglobulin will be positive. But here in mature B ALL, which will be positive? Surface immunoglobulin will be positive. So most of this B cell lineage ALL, which is most common, incidence of common ALL, that is, it is seen in 49% of the patients. Then we take this pro-B-ALL. So this corresponds to early B-cell differentiation, and this pro-B-ALL, it was called as non-B-ALL or null ALL, because neither T cell nor B cell features could be demonstrated. If we take this pro-B-ALL, so this is early B cell differentiation. So this pro-B-ALL, so in this pro-B-ALL, so this comprises 12% of adult ALL. So this subtype is HLA-DR, TDT and CD19 positive. Again to this pro-B-ALL. So what is positive here? HLA-DR, TDT and CD19 positive. So this comprises 12%. And mature B-ALL 4%. Mature means surface immunoglobulin. Pre-B-ALL means cytoplasmic immunoglobulin. Pro-B-ALL, we have this HLA-DR, TDT positive and CD19 positive. Mature B-ALL is seen in 3 to 4% of adults, and it is also known as Burkitt's leukemia. So in Burkitt's leukemia, so which are the cells which are positive? So in Burkitt's leukemia, mature B cells are present. So Burkitt's leukemia means mature B cells. So in mature B cells, which is a surface marker? It is surface immunoglobulin. So in mature B-ALL, blast cells express surface antigens of mature B cells, including the surface IgM. Then coming to T cell ALL. So T cell ALL, approximately 25%. So B cell, it is approximately 75%. T cell, it is 25%. So in adults, 25% could be T cell lineage. So the leukemia could be from T cell. So all cases express the T cell antigen CD7 and cytoplasmic CD3 or surface CD3. So these are important. So T cells, what they will express? These T cells, they express CD7 and cytoplasmic CD3 or surface CD3. All cases of T cell leukemia, they express the T cell antigen CD7, they express cytoplasmic CD3 or surface CD3. According to their phase of T cell differentiation, they may express other T cell antigens. So according to the phase of T cell differentiation. So in all cases, you can see this CD7, cytoplasmic CD3 and surface CD3. And according to their phase of T cell differentiation, they may express other T cell antigens. So what are the other T cell antigens? The E Rosette receptor CD2 and or the cortical thymocyte antigen CD1A. Again, so T cell antigen. So in T cell lineage ALL, cytoplasmic CD3 or surface CD3. So again here we can see, so here we have three types, okay, mature, cortical and early pro or pre-T ALL. So here it is mostly CD2 negative. Cortical TAL, in cortical TALL CD1A is positive, and in mature TALL CD3 is positive, CD1A is negative here, okay. So 25% of adult ALLs or T cell, all cases express T cell antigen CD7 and cytoplasmic CD3 or surface CD3, and according to their phase of T cell differentiation, they may express other T cell antigens. So what are the other T cell antigens? E Rosette receptor CD2 and or cortical thymocyte antigen CD1A. So early pro or pre-T ALL, also termed early T precursor ALL, cortical or thymic ALL, and maturity ALL can be distinguished with these markers. So if we take this early pro or pre-T ALL, so this is characterized by a lack of CD1A and CD8. If we take this early precursor TALL or early pro or pre-TALL, so how is this characterized by? So this is characterized by lack of CD1A and CD8, weak CD5 expression, and at least one myeloid or stem cell marker. So if we take the early pro or pre-TALL, so this is characterized by lack of CD1A and CD8. This you have to remember like this only. So this is characterized by early pro or pre-TALL. So this is also termed as early T precursor ALL. ETP means early T precursor ALL. So this is characterized by lack of CD1A and CD8, lack of CD1A and CD8, weak CD5 expression, and at least one myeloid or stem cell marker. Early T precursor ALL characterized by lack of CD1A, lack of CD8, weak CD5 expression, and at least one myeloid or stem cell marker. Biphenotypic or mixed leukemias. So biphenotypic or mixed leukemia, so they are defined as those expressing biphenotypic means they will express both lymphoid and myeloid lineages on the same leukemic cell. So these leukemia cells are there. So they'll be having both myeloid lineage as well as they're also having this lymphoid lineage. Bilineage leukemias are those with two population of blast cells with either lymphoid or myeloid antigens. So it is not clear whether these patients they should receive an ALL or AML treatment protocol. So because they're having two population of blast cells, so because they're having two population, it is not clear so what treatment they should receive. So they should receive an ALL or AML treatment. In pediatric studies, starting with the pediatric ALL protocol, it seemed preferable, which was then followed by AML consolidation elements. So we sent for immunological studies, that is flow cytometry of the peripheral blood. So this flow cytometric histograms in B-cell acute lymphoblastic leukemia. So here we can see the 86% of these cells, no? So these are TDT positive. The cells are CD45 positive. Here it is CD45. And here you can see this, they are TDT positive. And here okay, sorry, this is CD34 negative, yes, TDT positive, CD34 negative, and here you can see the cells which are CD10 and CD19 positive, co-expressing both CD10 and CD19. And immunohistochemistry from lymph node biopsy, it shows positive staining for terminal deoxy transferase. Lymph node biopsy. So in lymph nodes also cells will be there, no? So these are positive staining for TDT. So here we have the so in B lineage ALL, so whenever there is ALL, first we should know whether it is B lineage or T lineage. So in B lineage we have this pro B ALL, we have common ALL, pre B ALL, mature B ALL. So what are there? Pro-B ALL, common ALL, pre-B ALL and mature B ALL. So 49% is common ALL. So this is CD10 positive. Mature B cell surface immunoglobulin is positive. T lineage ALL, early pro, no additional or differentiation markers. Early pro or pre-T ALL, cortical T ALL and mature T ALL. And then cytogenetic and molecular analysis. Cytogenetic and molecular analysis should be performed in all cases in ALL, whether it is T cell or B cell ALL. So this should be performed. So why? Because they are important to define the ALL subtypes. So here we can see the different cytogenetic aberrations. Okay, so in all this because we should know the cytogenetic subtypes. So it could be T922 or it could be T411 or 814, 822. So all cytogenetic aberrations or genetic aberrations and fusion transcripts. So why this is important? Because it can identify independent prognostic markers of disease-free survival and may determine specific targeted therapies. So how to do the cytogenetic and molecular analysis? So for this, these are the diagnostic techniques. So what are the diagnostic techniques? Either it could be a standard cytogenetics, FISH or reverse transcriptase polymerase chain reaction. So by these diagnostic techniques, either of standard cytogenetics, FISH or reverse transcriptase PCR. So these methods, no, they allow the detection of Philadelphia positive ALL with the chromosomal translocation 922 and the detection of the BCR ABL1 gene rearrangement. So if we do this techniques, no, a FISH, what can we detect? We can detect this Philadelphia chromosome positive ALL. That is, there is a chromosomal translocation in 9 and 22, and we can also detect the corresponding BCR ABL gene rearrangement. And apart from this, because this is commonly known, BCR ABL T922, and further ALL entities have also been identified. So what are these further ALL entities? So these are T411, MLL AFA4, and we also have this T119 PBXE2A. So these are the further ALL entities. Like T922 BCR ABL gene rearrangement, we also have further ALL entities. So these are T411, MLL AFA4, T119 PBXE2A. And gene expression profiling, single nucleotide polymorphism array analysis, array comparative genomic hybridization and next generation sequencing. So they recognize the newly defined ALL entities. So newly defined, what are these newly defined ALL entities? So these are ETP ALL and Philadelphia like ALL. So if we have to diagnose this newly defined ALL entities, so we have to use this gene expression profiling, single nucleotide polymorphism array analysis, array comparative genomic hybridization and next generation sequencing. If we take this Philadelphia like ALL, so this is also known as BCR ABL1 like ALL. So how this like ALL, no? So this is characterized by genetic lesions will be similar to Philadelphia positive ALL associated with IKJF1 gene deletion, CLRF2, that is gene for cytokine like receptor overexpression, and tyrosine kinase activating rearrangements involving ABL1, JAK2, PDGFRB and several other genes, but however it is BCR ABL1 negative. Okay, Philadelphia like ALL. So this is also known as BCR ABL1 like ALL. Here what is negative? BCR ABL1 is negative. So this is characterized by genetic lesions similar to Philadelphia positive ALL, like Icaros gene deletion, CLRF2 receptor overexpression, and tyrosine kinase activating rearrangements, and several involving ABL1, JAK2, PD, GFRB, and several other genes, but it is BCR ABL1 negative. So, what is the frequency of this Philadelphia like ALL? It is 10% in children and 25 to 30% in young adults. So, but does not increase further with age, like Philadelphia positive ALL. It is Philadelphia like ALL. Frequency of this Philadelphia like ALL, it is 10% in children, 25 to 30% in young adults, and it does not increase further with age, like PH positive ALL. It increases with age. As age increases, so this also increases. But this Philadelphia like ALL, no, so it does not increase with age. And treatment based on the underlying genetic lesion with BCR ABL inhibitors. Example, dasatinib or JAK2 inhibitors. Ruxolitinib had so far had limited success. So because there are some translocations, no, we can try. This treatment has been tried with BCL ABL inhibitors, dasatinib or JAK2 inhibitors, but this has had a limited success in adults. So that is about acute diagnosis and clinical features of acute lymphoblastic leukemia.